I'm so pleased to introduce our speakers for today. Dr. Chris Rhoads is a psychologist at Harborview and a UW professor of neurology. He specializes in evaluating and treating dementia and neurodegenerative disorders. His clinical interests include neuropsychological evaluation of neurodegenerative disorders, non-pharmacological treatment of memory and neurological disorders, cognitive rehabilitation, and cross-cultural evaluations and treatment. His research interests include screening and early detection of cognitive impairment, non-medication interventions for memory loss, and cross-cultural dementia care. And Lynne Korte is the Dementia Care Program Policy Analyst for Aging and Long-Term Support Administration with Washington State DSHS. She's been in the field of aging for 30 plus years. She has specialized in the development of services for people living with dementia and their family care partners. Working for Washington State, her key responsibilities include managing community partnerships within federal Alzheimer's demonstration grants, state program and policy development, and the development and implementation of the Washington State Plan to address Alzheimer's disease and other dementias, including oversight for the plan's multi-sector guiding body, the Dementia Action Collaborative. So I think you can see they're incredibly qualified and have expertise to share with us today about developing and implementing a state dementia plan in Washington State, particularly regarding progress and lessons learned. Welcome to our speakers.
Oh, thank you very much, both for the lovely introduction and just the invitation to come chat with this fantastic group. I have had the good fortune of doing some presentations for this series, usually on driving and dementia, so it's fun to talk about something else that's not a super heavy topic. So we will get into it, and I want to thank Lynne also for agreeing to co-present this with me. I really couldn't imagine doing this without her, both the work itself, but specifically the presentation too. So thank you all for that. And the audience, I know this is a huge group with a lot of diverse expertise in a bunch of different regions. I saw Toronto in the chat, so that might be the distance record. I'm not sure, but pretty amazing that you're all choosing this for your activity this afternoon or evening. So I really appreciate that. It means a lot. All right, so let's see if I can do this. I am working in a different place on a different machine, so it's going to be a fun learning experience for me too. So the hope for this was to talk very briefly about some statistics. I think in this series you've already heard plenty about that, but there are a few things I wanted to reiterate, I think set the stage for the work that we're doing here in Washington, and then to talk about how what we are currently doing has unfolded over the last, dozen years, I guess, maybe more than that, to talk about the background of the state plan, and then to kind of take you on a tour of what we have achieved. Hopefully, some of this is not new to you, that you're already aware of some of these great programs, resources, supports, and services, but be great if there's some new information there too. We will then talk about the updated plan, some lessons learned. I feel like, depending on where you are attending from, your state either has a plan, is in the process of updating your plan, or there may be a few states without plans yet. And boy, if you haven't, you can capitalize on a lot of the great work that's already been done, which is exactly what we did, learning from states like Minnesota and Oregon and California, who have done amazing work, not just creating a plan, but then implementation and some tools. And then last but not least, for the formal presentation part of things, is to talk about how you can help, in addition to just being the fantastic providers and good people that you are, doing the work for the right reasons. So again, just very broadly, this is a massive worldwide problem, and we know that there are somewhere in the neighborhood of 10 million new cases of dementia each year around the world. And the majority of those, about almost 60%, are in low and middle income countries. That percentage is just going to increase as people are living longer in those countries. And we also know that these numbers are hard to estimate and may just be kind of tip of the iceberg in that, the majority of people with dementia do not have a diagnosis, right? So here in the United States, including Washington, only 45% of people with dementia have a diagnosis documented in their medical record. What's also kind of mind-boggling and interesting is about that same number, about 45 to 47% are told about that diagnosis. So the majority are not. And I think that really belies the amount of work that we have to do around empowering our primary care and other allied health care providers with the tools to diagnose, scripts, and how to talk about this, and then the program services and treatments that are available to get past some of that diagnostic barrier. And then in other countries like India, only 10% of people with dementia have a diagnosis. So there's some difficulty in estimating the actual prevalence. We do know that age remains the greatest risk factor, and our general risk in the population somewhere around 10, 11%. After the age of 65, that goes way up. By the time you're in your mid-80s, it's 35 or so percent. Although, it's also notable that many people with the biological hallmarks or the pathological markers of Alzheimer's disease, the amyloid beta plaques and the hyperphosphorylated tau tangles, will not go on to develop the full-blown clinical syndrome. So, again, some difference between disease and the dementia that accompanies that disease. So we've got, again, lots of people aging into that risk zone. I like the age wave better than the silver tsunami. That's a kind of a negative forecast tsunami, but it's an age wave. You gotta ride it. So here we've kind of already talked about the general risk, but best guess is that there are about 7 million Americans here with Alzheimer's dementia, another maybe 6 million with MCI, 3 million of which are due to things like Alzheimer's disease or Alzheimer's specifically, which, if my math is correct on a Thursday afternoon, means there are 3 million with other things that are causing MCI. And that really behooves the importance of an early and accurate diagnosis as we think about some of those, arrestable, potentially reversible, or treatable causes of cognitive change. And then on top of that, for people over the age of 45, there are 15 million with subjective cognitive impairment. And not all of those are kind of the prodrome of something like Alzheimer's disease. But I think historically, we've done a bit of a disservice to this population by categorizing them as perhaps hypervigilant or the worried well. And what we know is that especially insightful and fairly bright individuals, and even across the continuum, people are pretty good at detecting when something is changing. They're not always good at disentangling the etiology of that, but there's a huge population that may be detecting things internally before the traditional clinical tests that we have would pick up changes, especially people with high kind of cognitive reserve and premorbid abilities. Our tests aren't as sensitive at either end of the intellectual continuum. Let's see. Oh, also, I guess back to this, if we look at this kind of projections for age, and this probably looks familiar to many of you, it's this group of our older adults, the 85 plus group, that is the group that is rapidly expanding, whereas there isn't much change across time from 2020 to 2060 or so for our 65 to 74-year-olds, who only have about a 5% risk for Alzheimer's dementia. I also want to be very clear, this is one of my areas of both clinical and research interest, particularly working with our tribal populations, our American Indian, Alaska Native populations. There are significant disproportions and disparities that are obscured by those broad numbers. So this includes women who are doubly impacted by dementia, in that 2/3 of all people living with dementia are women. And moreover, 2/3 of all caregivers or care partners for people with dementia are women. And these are often elderly spouses or people who have their own cognitive changes or health conditions, or the sandwich generation. And there are multiple reasons for this. Some of it maybe is survival bias, in that men tend to die earlier from things like heart disease, cancer. Some of it may be interactions between genetic risk factors and hormones. That's a little murky. And some of it is absolutely kind of the more educational, occupational opportunities for a certain generation of women, which were very different than that for men, which lead to different stresses, different access to healthcare. And so there's this real kind of biopsychosocial component that drives that differential risk. Same is very true for non-Caucasian populations. So we know that our Black and African-American older adults are twice as likely to develop dementia as their Caucasian counterparts. Our Hispanic and Latinx populations are a time and a half, maybe 1.6, 1.7, depending on the subgroup. And this is an important kind of a theme too of the ethnic gloss of, you know, categorizing widely different heterogeneous groups as, you know, a particular ethnic group. You see that in our tribal populations too. So really, you have to drill down on these things. But you know, with our Hispanic and Latinx groups, typically diagnosed at a later stage with more severe symptoms. And for our American Indian Alaska Natives, also maybe 2.5 to 1 compared to Caucasian counterparts, with a whole host of different kind of risks depending on location and you know, urban versus rural, and coastal versus plains. There's some significant differences there. All right. So if we drill down and get a little Washington specific, because we are talking about the Washington State Plan. So here in Washington State, we have about 7.5 million people. For those of you that are between Everett and Tacoma, like myself, it feels like about 6.5 million of those people live in that zone. But we have a ton of population out in our rural and kind of outlying areas, not just the kind of I-5 corridor. So we've got a growing population here, and especially a growing population of older adults, some parts of our state more than others. We know that we have about 127,000 cases of Alzheimer's dementia, still projected to be somewhere around 145, 150 by 2030 or so. It remains the third leading cause of death behind heart disease and cancer. When I first started keeping track of this, we had the third highest mortality rate in the United States, behind North Dakota and South Dakota, and now we are the ninth. Some of that, I would love to think some of that is the amazing job we are doing taking care of people living with dementia, and they are living well and dying from other things. I don't know how much of that is true, but some of it is also other states accounting for or naming Alzheimer's disease as a cause of death when it is a cause of death. So there's a little bit of an accounting issue there. There certainly has been plenty of evidence of an uptick in deaths for individuals with dementia during the peak COVID years. So if you look at the rates, the mortality rates for the 5 years before the pandemic, and then compare the 3 to 4 years during the peak of the pandemic, there's a 16% increase during that time. And for any of you with family or friends, or people that you work with, or patients, you know how hard the dementia population was hit during the pandemic with disruptions in routines and access to preventative health care. And we're still digging out of that, at least here at Harborview and the University of Washington. And these numbers are the ones that I think kind of strike me the most, maybe trouble me the most in some ways, that the number of people who provide care, unpaid care, right? So these again are elderly spouses, family members, neighbors. There's almost 2.5 to 3 to 1 for every person with dementia, someone who is providing a significant amount of care. And if you look at the workforce we need to take care of the 10% or so of people who are going to develop dementia after 65, just geriatricians, we've got about a third of what we need. And this is a huge financial issue in that it's a massive unpaid industry, and both in terms of how much we would have to pay people if we were paying them to provide care, but also how much stress it puts on the caregiver, right? It's physically exhausting, it's emotionally exhausting, it's financially depleting. So this is tough on our care partners. And not to present these as a doom and gloom and oh my gosh, dementia is going to bankrupt Medicare if we still have Medicare, but a need to start thinking about what can we do at the systems level to buffer and augment our workforce, our supports, our services. So to entertain that question of, okay, in Washington, we've got 250,000 unpaid caregivers. What happens if 10% of that workforce can no longer do the jobs they're doing because it's hard on them physically, emotionally, and financially? Do we have the resources at the state level to step in and pick up that slack? And the answer is a resounding no way, right? We're not even close to that. So these numbers, I think, help drive some of the policy changes and ultimately drive the initiatives and the funding that we received to do some things about this. And here, again, just a little bit more data around the forecasts for growth here in Washington State for people over the age of 65. So just like in that national sample from the Alzheimer's Association, if we look from 2020 to 2040, not a huge change in that 65 to 69 band, but in those 20 years, the number of people who are 85 plus in that highest risk zone for not just Alzheimer's disease, but all form dementia, we are more than doubling that population. So it is high time to make sure we've got the things in place to help keep them doing well. The other thing that these numbers and this work really kind of points out to me is the need to address the stigma that persists around dementia. And that stigma and nihilism is part of what drives those low diagnostic rates and communication rates. But it's also what drives the fear that keeps people from talking with providers in those earliest stages where the window of opportunity for intervention is the widest, right? So we've got this kind of cultural narrative that, Alzheimer's disease equals end-stage dementia when you can't communicate, you're bedbound and agitated and need help with even your basic ADLs. That is absolutely not the case. And it's one of those things that it's been lovely to see some efforts to undo some of that stigma. We're going to talk a little bit about that later on. But boy, one of the things that I love about where I work and what I do is we are a strengths-based kind of resiliency focused, not to negate, losses and changes, but how do you lean into a disease like this? And how do you recruit those retained strengths to compensate for weaknesses and changes and put some scaffolding around somebody to keep them engaged in their community and their lives to the best of their ability with modifications and changes. So that's a big push. And I think at the heart, not just of what we do at Memory and Brain Wellness at the UW, but at the heart of the Dementia Action Collaborative and our state plan working group. So with that, I'm going to turn it over to Lynne, and I am happy to continue to click on slides. Lynne, you are muted. Just a
Whoops, thank you. Thanks, Barbara, for the invitation to be here today with your group. So happy to have all of you here today as we share some of the lessons that we've learned along the way over the last 10 years. And thanks, Chris, for setting the stage so nicely to share where we started our work first with the Washington State Plan for Alzheimer's and other dementias. So just as a bit of background, it might be interesting for some of you to know how this movement started. It actually started at a Governor's Aging Summit in 2013, where aging and dementia advocates had come together to address the imminent age wave that Chris was talking about, or the aging of the baby boomers. So at this summit, the group was working to identify a lot of issues around aging. And one of the things they identified was to use a strategy of a state dementia plan as a way to prepare for this growth, because we knew with the aging of this baby boomer population that there would be more and more people who had Alzheimer's or other dementias. And interestingly as well, the year before that, the National Alzheimer's Project Act, if you're familiar with that, was signed into law by Barack Obama in 2011, which led to the development of the first national Alzheimer's plan in 2012. So there was this sort of synergy and this sort of increased interest to think about what could we do both nationally and at the state. So in the 2014 legislative session, some Washington state aging advocates put forward a piece of legislation, and the state legislature authorized the development of a state Alzheimer's plan. So that would be our first state plan for Alzheimer's and other dementias. So this legislation had required DSHS to convene an Alzheimer's disease working group. And it designated the Aging and Long-Term Support Administration, because we are a piece of Department of Social and Health Services, our assistant secretary, who was then Bill Moss, to act as the chairperson for that group. So ALSA then subsequently appointed a roster of 34 members as defined, sort of scripted out in that legislation. And you see those members up on the screen. And it is sort of really important to note that this was considered as a very broad partnership. So, it had members from the state, from the government, such as representatives from a variety of state agencies. It included legislators, representatives from both the House and the Senate of the legislature, the state legislature, and representative from the governor's office. But it also included a lot of private partners. Providers such as a neuropsychologist, providers such as long-term care providers, providers of assisted living, nursing homes, adult day services. It included other health providers, social workers, advocacy groups, and importantly, it did include representation from individuals who were living with dementia and family caregivers. So this group we convened it in 2015, and we worked over the period of a year to develop the plan. So we had multiple full group meetings of that whole group, and we had different subcommittee meetings where we broke into specific topics such as healthcare, long-term care, family caregiver supports, groups that were sort of separate to discuss different issues. And we completed also statewide surveys. We had a provider survey that we sent out, we had a consumer survey, and we held listening sessions so that we could listen to consumers or other professionals to hear what they thought in our first Alzheimer's plan that we might consider as the most important needs and what we needed to address in the plan going forward. So just as a point of note, Chris was one of our original members back then, and he has continued on. He was the chairperson of our health and medical subcommittee, and he's continued on the Dementia Action Collaborative to this day as a member of the steering team and a chairperson. So we've just been so fortunate to have somebody like him who has continued on providing the kind of support and commitment that he has. So if we go to the next slide, I do want to share that the plan was published in January of 2016. And you see the group here. Chris is in back, and if you notice, Chris's eyes are closed. I'm sorry about that, Chris, that I used that picture, but it was the best picture where we had the governor and the other members. And the thing that was really exciting about that is we were able to present that to the legislature on a day when a lot of the members came, members of the Alzheimer's Association came, and there was a lot of passion and excitement in the room at the time because this was a very, very committed group. So the first plan, I don't know how many of you might be familiar with it, but we had 7 high-level goals. So those were things like increasing public awareness, preparing communities for growth of dementia, promoting safety and well-being of people living with dementia, increasing family caregiver supports, identifying dementia early and promoting evidence-based healthcare, improving access to long-term supports and services, and innovation and research around dementia. So in all, the plan had about 130 individual recommendations. So we knew there was a lot of work ahead. So included in the plan was this recognition that the legislation that had authorized it sunset when the plan was published. So there were no funds that were provided for the development of the plan and no real funding or plan for how it was going to be implemented. So our group had decided in the plan to include a call to action, and that call to action was to form an advisory group that would implement the plan. So I was recalling at that point, one of the first times the whole group got together to develop the plan, we had asked the group, when you do your process, what do you want out of this plan? And the most resounding answer we got was, we don't want it to be a plan that sits on the shelf. We don't want to create something that's not going to make a difference. So even though we had no funding at this point, after the plan was developed, we asked these members of the Alzheimer's Disease Working Group, who of you would be willing to come back and to continue to support the implementation of the plan, albeit on a voluntary basis? Because again, we had no funding, we had no mandate, because that had ended. So every person who had been involved, except 2 people who were retired, had said yes, they would want to come back, because this was just, again, this very passionate group who was committed to the issue of dementia. And I think the group had really bonded during the development of the plan. So they really wanted to see it forward. So what you could see on this screen when you see these sort of stepwise actions that you see on the screen is in early 2016, after we'd had that discussion, we formed ourselves into this new group called the Dementia Action Collaborative. And we did have most of our continuing Alzheimer's disease working group members. And we continued on at DSHS, Aging and Long-Term Support Administration, to provide the leadership and some of the in-kind support, including Bill Moss, who stayed on as the chairperson, and myself to support the work. We also had formed our steering team, which again included Chris and the other chairpersons of the different subcommittees and a representative from the governor's office. So at that point, we were discussing how can we move this forward? Even though we've formed this group, we've got to figure out how do we do this with no money. So if we go to the next slide, I do want to mention that we really had this strategy, and the steering team had thought long and hard about this. What could we do with existing funding that various agencies or partners had, or what could we do through heightened collaboration? So, you know, we had formed ourselves into these different subcommittees. So we had 3 topic focused subcommittees: health and medical, we had public awareness and community readiness, and then we had long-term supports and services. But we have a 4th committee called advocacy. And those are many of the advocate groups that came together to get the plan started and were very willing to stick around and help with some of the advocacy issues we might need as we move forward. So a few of our first projects that you guys may have heard about were the creation of resources. So we had really used the expertise and the input of the group, because we had a lot, you know, this broad-based group of experts. And we created something called the Dementia Roadmap, if you've heard about that, which is a guide for family and caregivers. We'll talk about that later. We developed something called the Dementia Safety Info Kit. We worked with the BRE Collaborative, which is a governor-appointed group, which is run by the Healthcare Authority. And their role in the state is to identify best practices that might be considered for some value-based purchasing, or to sort of help with the continuity and the consistency of care. So those were things we were able to leverage from within our own group and within the kind of funding that we had, which was minimal at the time. So if you go to the next slide, you'll see the next step in our process was that one of the recommendations that was in the plan was to have liaisons, staff liaisons in 4 different state agencies. And this was something that turned out to be a very pivotal move, because the advocates went to the state legislature in 2018 and said, could we have part-time funding, so just part-time, in 4 of these state agencies to help implement the plan? So this would provide a half-time person or half-time work of a person towards the plan. In DSHS, we have Aging and Long-Term Support Administration and the Developmental Disabilities Administration. And then we had funding for somebody in the Department of Health and in the Healthcare Authority. So fortunately, this passed, and we were then able to bring on this part-time staff in these 4 state agencies to help support the ongoing work of implementing the plan. So if we go to the next slide, what you'll see is that we then had staff in these agencies. So this staff liaisons and the support team works to integrate the goals and objectives that are in the plan that are related to dementia in their own respective agency strategic plans. So to see how could we fit this into our ongoing work. And then we worked to identify recommendations in our topic areas that might be implemented in our agencies, perhaps through existing resources. So we're always looking for ways to integrate it into the work that our agencies do. Another role was to coordinate and support the work of specific DAC, or Dementia Action Collaborative subcommittees. And those subcommittees are working sort of cross different sectors on their topics, but we really needed staff to support that work, because those first couple of years, it was me and a whole bunch of people that I was trying to sort of keep on track and keep communications with. So adding in some more staff support really helped to start bringing a little more structure and a little more support that we could provide to the process, really connecting what's in the plan to what we're doing now and what we need to be doing in the future. So this staff team has really created, I think, a more sustainable way to implement the plan and move the recommendations forward. So if you look at the screen, we have the staff people, and then we have this broad-based group of stakeholders. So again, we have government agencies, we have legislators, we have people from the Aging Network, people from advocacy groups, long-term care, healthcare, sort of all working together and sort of available to each other to share their expertise, to help each other when they have questions, and to sort of figure out how can we navigate all these different systems that need to work together. Okay, so let's go to the next slide. So here you see the rest of our pathway. You see on this little map, we started with the development of the plan. We did some of the things we could through existing resources through 2017. We got the staff, the part-time staff, in 2018. And at that point, we started really digging into the plan and saying, what are the first things that we need to do to set the stage for progress? And as I had mentioned before, one of the things that we really wanted to focus on was having sort of more early or timely diagnoses of dementia, because at that point you have a longer runway. You can do more to help a person. They can do their legal and financial planning. Treatments can be put into place where they exist and what's good for the person. And people can really start to get their team built around them. So we knew that we really wanted to promote that, but we knew it couldn't be just coming out of healthcare alone. So we proposed 4 different initiatives, and 3 of them were funded, and they were closely tied together. So those first 3, they were funded in the 2019 session to start in 2020. So the first one was Project Echo Dementia, and you're going to hear a little bit more about that soon, which was targeting primary health care and helping them to understand how to better identify dementia, how to diagnose, and then how to treat. The second initiative was public awareness around dementia, sort of helping people to understand what are those signs and symptoms and what's the value of an early diagnosis, because we knew there needed to be something from the consumer side as well. And we put into that we wanted particular attention because we knew we weren't going to get a whole lot of money, that we wanted to really focus that on populations that were at elevated risk of dementia, such as the Black and African American community or Latino communities. The third initiative was to promote early legal and advanced care planning. So we'll talk a little bit more about each of these initiatives later, but these got started, we got funding, and were able to start them. They were right in the midst of the pandemic. So, things probably didn't go quite as smoothly as they would have without that, but they did get started. And, they still exist to this day, and we've evolved them and improved them as they went. So our next set, when you look at this little pathway, was as I said, we only got 3 of the 4 that we asked for. The fourth one, which was something we wanted to do to acknowledge that once you're starting to identify people early, we want to have community resources available for them, right? To help them with the planning and the support that they need. So we wanted to develop, and we looked at different models from across the country of how could we promote more dementia capability, more dementia-friendly communities, more assistance for people with dementia within their communities themselves. So we had these pilots that we put forward called Building Dementia-Capable Communities. Some of you might have heard of this as a dementia resource catalyst. What we did was we provided funding for area agencies to have a planner or a resource developer, and along with some service money that they could deliver things that were missing in their community. So we got funding for 2 at one point, and then we added a third. And then you see on our little journey map here, the following year, we got money to fund a statewide program to expand a pilot we did called Dementia Friends. And again, we'll talk in more detail about these programs, but I just wanted to show you sort of the flow of the milestones of how we were working to integrate this sort of concept of supporting early diagnosis and support and planning for people. Okay, so if we go to the next slide, Chris, I think we're going to go over to you for the set.
Lynn, I'm wondering if I can pose a question that was mentioned by May. She had said that, and so what you've been describing may be a context for the chat message, which was trying to, that there was funding for parents to care or children to care for their parents, but not for spouses, and it sounds like there's been a delay in getting that system in place. Does that ring a bell for you?
You know, it is not my program to manage, but what I do know is that we have some different Medicaid funding that can be used in different ways. And up until now, spouses could not be paid, primarily adult children, or, you know, if you have a niece or a nephew, other families can be paid to be either individual provider, it's called. And there has been a move to do that. I know the WA Cares Initiative, or the Long-Term Supports and Services Trust, is also moving in that direction. So I think you're going to start seeing those sort of emerge, but there are a lot of policy considerations to doing that. And if somebody wants to have more specifics on that, I could talk to the program managers for that to see more about that, but I don't have the specific dates or when that is actually going to happen. But it has been in discussion, and I think they're moving in that direction.
Well, that's helpful to just put it into that context, so thank you.
Sure.
All right, and thank you, Lynn, for such a good overview of the history. You know, you have been the people have referred to you as the spark plug that has kind of made this whole thing. I maybe more like the engine, but this, you know, of all the really amazing things that I get to do, I feel really fortunate in I get to do a lot of really cool things. The involvement with both the State Plan Working Group and the Dementia Action Collaborative has been such a rewarding and meaningful collaboration. And I think, I was thinking about it as you were talking, I think one of the active ingredients that has made it so effective and such a great experience is there's been a ton of ownership without ego, right? I mean, there's been a lot of like investment without like, you know, the UW has to own this or ALTA has to own it. I mean, it's really just truly been a collaborative with a lot of super smart, high achieving, opinionated in good ways people, but just the fact that, you know, it has gotten so much done is pretty incredible. And I think it's partially relationships, and it's partially just that doing it for the right reasons. So some of the stuff that's come out of it, and I'm going to kind of lean on the clinical things here because that seems to fit with our audience and our charge. Oh, I see a heart floating up there. That's nice. So the piece that another super cool thing that I get to do is Project Echo Dementia. And many of you, I'm guessing, are familiar with the Echo model. And if you're not, this is something that comes out of the University of New Mexico, started with hepatology and the idea of building up expertise in rural and underserved places where there aren't a lot of specialists, but training people with kind of specialty level knowledge. And it's really an effort to demonopolize expertise and make sure that, you know, the people who know their patients the best, primary care and other frontline healthcare providers, are the ones that have the skills to do the work, and kind of dovetails with the shortage of specialists. And boy, driving to Harborview and parking at Harborview is painful. I see people from all over. So boy, if you could get that level of care in your community, that would be pretty awesome. So that's the goal. And with Echo, there's a kind of a hub team of interdisciplinary, and I'm going to use that word very carefully, versus multidisciplinary, because I really do think we all kind of contribute in ways that add up for the whole being greater than the sum of its parts, versus a tossed salad kind of specialists. But there's the expert, quote unquote, expert hub. And then there are spoke sites. And the model is that there's a short, clinically relevant didactic. So something like, if you're going to do cognitive screening, what are the measures you could or maybe even should use? How do you interpret them? What do you do next? You know, very, very pragmatic. How do you bill for it? Or, you know, deprescribing, you know, it could be any topic. But, you know, 15, 20 minute, we like to talk. So sometimes it's like 25 to 30 minutes, you know, a didactic. And then ideally case-based learning. And sometimes it's a formal case, sometimes it's kind of clinical vignettes or clinically relevant questions. So it's not a webinar, right? I mean, it's dynamic and interactive. And there's a whole kind of philosophy about how you solicit input, and which it's super cool. But the thing that was amazing was to be able to go to the Joint Legislative Executive Committee and say, hey, we just did this great work with the BRE Collaborative, codifying best practices around dementia. We now need a vehicle to disseminate it, and this is a great one to do it. And back in 2019, I guess it was 2018 when we did this testimony, or went down and talked with them. You had to explain what Zoom was because it used Zoom. That was the format for Echo, and they were an early adopter for Zoom. Now everybody knows what Zoom is. But the principles, in a way, the pandemic was a bit of a gift in very few ways, but in the way that it really opened the door for this kind of a format for learning. And we were able to also say, this model is great not just for healthcare and dementia care, but also programs and services. And we'll talk a little bit about kind of the sister program to ECHO, the Dementia Friendly Washington Learning Collaborative, which maybe some of you are part of that too, which would be awesome. So our hub, we have representation. The other thing that I am super proud of is that this is not just a UW. We administrate it through the Department of Neurology, which is great. But my co-lead, Dr. Nancy Eisenberg, is at Swedish Providence. Our pharmacist is at Overlake. Our palliative care hospice person is at Virginia Mason Franciscan. So this is a cross-institutional effort, and that's kind of rare in healthcare, especially with our biggest competition in some ways. But it happens, and it kind of works the way it works as a product of the Dementia Action Collaborative, or the DAC. We typically have about 20 to 25 spoke sites, mostly primary care, but some allied healthcare providers, some specialists too, from all over Washington. Sometimes it's a single provider out, in a rural community. Sometimes it's somebody part of a large healthcare system, some group practices that are involved. We meet for 75 minutes, the second and fourth Friday from 12:15 to 1:30. And because we are state funded, we can provide free CME and CNE. So it's a bonus. What I have come to find in the last 5+ years of doing this is the CME is not really the value proposition. It is being part of this community. And there's a couple of different ECHO models. Sometimes there's a cohort of 25, 30 clinics that go through a series of 10, the 10 dementia fundamentals. We thought about that very carefully and decided we wanted to build a community throughout Washington State. So we are an ongoing kind of, not a cohort model, it's more of a community-based. And here you go. So since we launched, we've provided, it's upwards of 1,750 instructional hours with, I think, oh my gosh, 250 zip codes. So, again, maybe some of these communities are where you are right now. And we are actively recruiting more folks. We've got a pretty good cadre of kind of regular attendees. We've got some folks that kind of dip in and out. We have really tried to eliminate or reduce the bar for entry and barriers to entry, including scrapping this extensive, case presentation form, which would be lovely if we had all that info, but nobody has that kind of time. So we really tried to make it easy. And we've got really great feedback. We have iterated this program over time based on survey data and our both post-session and CME annual survey data. About 70%, 75% say this was super helpful and I'm going to change my practice in a couple of ways. So that's always nice to see too. In an ideal world, we would have clinic level or maybe state level data that shows some things changing in communities where there are providers that are involved in ECHO, but that data is hard to fully make sense of. We've had some preliminary glimpses at some things, but it's a big dream also. We have also all of our didactics, and recently all of our didactics and cases are recorded and available freely. We have asked the state, bad timing, but we have asked the state for some additional funding to both kind of keep up with just cost of living increases. In the 5 years, our faculty and program has become more expensive, but our funding's been static. And we would love to be able to provide CME asynchronously, so for the things that are archived. But everything we've done for the last 5 years is on our website. You can watch those at your leisure. And then just a sample of kind of what we'll be talking about for this spring session. Here you go. So some cardiovascular risk, some behavioral things. We do a lot of non-pharmacological kind of talks. So you can see a few of those. The other program that is connected to the Dementia Action Collaborative and now connected to ECHO in some ways is the UW Cognition and Primary Care Project, which is a very, very pragmatic by primary care for primary care way to implement the GSA Care Toolkit, which is massive. It's overwhelming and it's wonderful, but boy, it's a lot. So very pragmatic. How would you build some of these into your workflow? There's a 3-part Zoom series. You can see the topics there. People who undergo this love it and make significant changes in their practice. We are reaching out to FQHCs here shortly to offer some financial incentive to basically buy out people's time to participate in either ECHO, cognition and primary care, or both. And that is thanks to a partnership with the Department of Health and their BOLD grant. So again, part of the Dementia Action Collaborative State Plan family, and it'll be fun to come back and talk about what comes of that once we've actually embarked on it. But if you're at an FQHC and our primary care provider and would like to be considered for that, the RFA will be out shortly.
Chris, M. Lawrence is asking if information about this is going out to, for example, medical school students and that sort of thing.
Yeah, wonderful question. Yes, so that has been a hot topic. I mean, med students, so here at the University of Washington, we have plenty of those, and we have opportunities to do some training, but boy, the amount of training medical students get in dementia and diagnosis and treatment is minimal. We have talked about ways to try to enhance that, incentivize ways to enhance that. So absolutely. Also with the other medical schools around the state, there's a lot of opportunity there, but boy, it's hard to add something to what is already a crushing load for them. But yeah, absolutely great. That's such an important piece of trying to reach people at all stages, and ideally the further upstream the better. But yeah, that's a great area of focus. The other thing I mentioned just very briefly, but the timing was really wonderful. I think that's another kind of, what is it? Luck is when preparation meets opportunity, something like that. But we happened to be finalizing the state plan right as the BRE Collaborative, which is this, as Lynn mentioned, a governor-appointed group of healthcare payers and other folks in the state. The goal is to decrease practice variance and really codify these are the best practices for spine surgery or antipsychotic use in kids. So they had thought about Alzheimer's and dementia for a while, but right as we were wrapping up the state plan, we were able to go to them and kind of pitch it as boy, the time is perfect to really, codify these and then be able to work with the state plan data or info to implement some things. So we spent a better part of a year in 2017, all the way from diagnosis to end of life care. What are the best practices for providers, hospitals, EAP programs? So it's a pretty comprehensive overview of what the healthcare authority ultimately signed as here they are. Here's what we should be doing for dementia. So that's available. It's due for an update. You can imagine that things have changed significantly in the last 8 years, including wrestling with monoclonal antibodies and other issues. And then I want to spend just a little bit of time. You're going to hear more about this, I think, at your next session. Mary Grace Becker, one of my favorite colleagues, will be talking about some of the dementia-friendly Washington efforts. But that other piece, that other side of the coin from ECHO is using that same philosophy and platform for people who are doing dementia-friendly programming around the state. So we meet monthly. We just met yesterday and had a fantastic overview of museum-based dementia-friendly program offerings around the state. There are people from library systems and spiritual communities and all sorts of different theater groups, but really incredible. Bellingham, Spokane, all over Vancouver, they're really doing great work. But that same kind of approach of all teach, all learn, and spreading these things out. Similarly with Dementia Friends, you can see that, my gosh, this has taken off. And this is another now state-funded initiative that's administrated through the Memory and Brain Wellness Center. We have a full-time person who is doing an amazing job with Dementia Friends and dementia-friendly work around the state. And again, I'm gonna keep this one short because you're going to hear a lot more about it next time. Incentive to come back. All right, I'll turn it back over to Lynn.
Thanks, Chris. So as I mentioned earlier, remember when I was talking about what we got in 2020, we received a small amount of funding to use towards some public awareness work. And as I mentioned, we had decided to really focus, because it was such a small amount, on communities that are at elevated risk, such as the Black and African American, Hispanic, Latino communities. So this money went to the Department of Health. As Chris said, we try to divvy up the money and have it so it's not all into one place. And we have a lot of different agencies implementing different things. So it takes some coordination to keep it going, but I think it's a way to keep a bunch of people engaged and talking to each other. So the money does go to the Department of Health. And over the last several years, it's resulted in the creation of numerous resources that can help community agencies reach these specific populations. So they've developed a web page which houses information in both English and Spanish. And it offers materials that can be accessed or used for free by any community agency. You can just download it, you can print it. These are messages about the signs and symptoms of dementia, the value of early diagnosis and support, and guidance around how do you have that conversation with a family member that you're seeing who might be having some of these signs and symptoms. So it's a lot of useful information. I'll put the link in the chat after I'm done talking, but you can get to this webpage. Some other public awareness work that they were doing is using these same materials and using some trusted contacts in these communities to create media campaigns. So they're targeting radio and news outlets that are that reach these specific communities. And we do it typically a month or two out of the year. We use the materials and then, hit some of these targeted areas hard with these messages about dementia and early diagnosis. We've also taken some of the money and used it to pilot some in-person awareness activities, again, using trusted messengers and organizations in these specific communities. And these few pilot projects that we've done are now feeding into a new federal grant where we're going to be able to be doing more of these sort of in-person or community-oriented type projects where community-based organizations and faith-based organizations are going to be able to take some of this material and start talking a little more about brain health and dementia and just getting the conversation going so there's more awareness and a comfort level around dementia. So if we go to the next slide, Chris, I do want to mention something that I mentioned earlier. As all of you know, we have way too many people who are living with dementia who haven't completed their legal and advanced care planning documents. They've not identified somebody who can make decisions for them near the end of life when they become unable to make those choices, or they haven't made clear what kind of care they want or don't want as they proceed towards the end of their lives. So this creates lots of challenges for families and for providers as well. It leads to situations where families can't take action on behalf of their family member, and to the point where people want to seek guardianship, which we all know is costly, time-consuming, and it's limiting. It's not really the optimal choice for anyone. So the Dementia Action Collaborative worked first to develop what was called the Dementia Legal Planning Toolkit. We'll show you that in a moment. And then we wanted to create a program model of how could we help people in completing these forms. So it's really essential that all of us working together collectively are helping people understand the importance of completing their legal documents, ideally before you get dementia. And if not before, very early, if we're starting to get to people in early diagnosis, what can we do at that point to make sure people are getting this paperwork and letting them document what their choices are while they are cognitively able to do so? So with that in mind, the Dementia Action Collaborative developed a plan and received funds for this model to leverage what we call our pro bono legal services throughout the state. So the money comes to our agency and we contract with the Washington Pro Bono Council. If you've never heard of them, it's a cool organization that works with 16, I think they have 16 volunteer lawyer programs across the state. So they're the ones that are out there doing wills clinics, going to senior centers and helping people complete their wills, their estate planning, helping them with documentation. And so we're building on something that already existed, but we're increasing their capacity to understand dementia and to work with people in completing this documentation. So they have created this cadre of, 30 to 40 volunteer lawyers from across the state who are willing to help people for free. And they're also going out to senior centers and going to wills clinics and helping people to not only be aware of the need to do this, but also how to do it. And they're willing to sit down for the time it takes. Usually it takes an hour and a half, but help people either in person or if they need to virtually or over the phone to make sure this documentation it gets done. So they don't do complicated things like guardianship, but they help people complete these forms of powers of attorney for finances and healthcare directives, and dementia directives. Next slide, please, Chris. So another program model we've been working on, I mentioned that we really wanted to have more community support for people once they get diagnosed, and we wanted to see what would it take to make sure that communities have different sort of supports for people at the local level. So this was what we called our Building Dementia Capable Communities program. And I mentioned earlier we had 3 pilot sites now. So I'm just showing you here on the map. This is where they are over in Eastern Washington. They are allied with our area agencies on aging. So we have that area agency over in the Spokane area that's serving several counties. Northwest Regional Council serving the Northwest area, 4 counties up there, and then on the Olympic Peninsula. So it's really their role to help increase awareness and abilities, both in the public and for their staff. So they do a lot of training of their own staff, aging network partners, so they know how to respond better. They're spurring new partnerships with different community organizations, trying to develop new services to fill gaps like memory cafes, walking programs, arts programs, and really to sort of get into areas of partnerships with first responders or healthcare so that they can do a better job of working at the local level to support people who are living with dementia. So these sites really, I think, are making a big difference. We just are in the process of an evaluation, and we're really finding that they're finding that the people who are going through the trainings and the consumers are really finding it helpful, and it's very well received, and it's making a difference for people. So on the next slide, I just wanted to share with you that, we're talking about a lot of resources. Chris has mentioned these programs that are there and the resources that are available. We do have a website. And again, once I'm done talking, I'll put this into the chat. But this is where you could go. You could find our state plan. You could find our annual progress report to the legislature. You could find a lot of these resources. You'll find sort of introductory information on the first page. And then you'll notice over on the right here, I've listed, there's specific pages for individuals and families, a specific page for healthcare providers, or for dementia-friendly communities. So I really encourage you to go to that site and keep up with what we're doing and be able to access some of the resources. So Chris, I'm just going to have you, can you share these ones on the clinical tools?
Of course, yeah, I'd be happy to.
Yeah.
Was there another question, or looks like not? Yeah. So there, just to, for the, clinicians in the audience, which are many of you, there is quite a bit here. We already talked a little bit about the BREE collaborative. We wrote up a, kind of what's the rationale for using brief cognitive screening tools, even though there's still no good evidence that would say universal screening is the right thing to do. But, there are occasions where you're going to want to do it. So there's a provider practice tool, which is excellent. One of our primary care colleagues said, just like, give us a flow chart. We just want a flow chart and how to do what we want to do or need to do. So there's, kind of, if you have an opportunity or a need, what are the tools you would use? How do you interpret them? What do you do next? And then also kind of managing dementia through the course of the disease into mid and late stage, including some end-of-life care issues. So there's another document that's extensive. And I want to give credit to the Minnesota Act on Alzheimer's group, who did the groundwork on many of these, and then we've modified them to kind of fit our state. So again, that idea of benefiting from the hard work and dedication of other state plans. And I had an opportunity to go out to Minnesota and meet some of their state plan architects, and it's been great to kind of collaborate across states too. And certainly there's lots of opportunities for education around dementia. So there's a list of those as well. Many of you are already familiar with the roadmap. If you're not, and take only one thing away from this talk, I would hope this would be it. I hope it's more than that, but this is really, I think, the showpiece of kind of what we have been able to achieve. This is just such a lovely, from kind of wondering and worried all the way through late stage dementia. What should we be thinking about? What should we be planning for? What are the resources to help with that? It's in English, Spanish, and Russian now. There's the opportunities there to order paper copies. It's also PDF versions online, and boy, there's a lot of these that are out around our state and other places. It's been interesting to see this pop up even in other countries that have kind of adopted it. So really amazing resource. I can't extol its virtues enough. Here is the actual dementia legal planning toolkit. So it's got some basic but good information around capacity issues and the importance of clarifying and codifying wishes. It's got some forms in it. You can download it. You can get paper copies. The Northwest Justice Project has been super helpful in crafting this and making some changes over time. But it really, I think of it as, and I usually talk about it as, for people who do not have access to an elder law attorney or any attorney to help with some of these basic documents, it will walk you through kind of what you need to do, and really demystifies the process. It makes it very doable. And there's a checklist. If you're going to meet with an elder law attorney, here's your checklist of things to get, in place before. Here's what you bring with you. So very, very thoughtful and a wonderful free resource. All right, I think I'm going to turn it back to you. We're about, I guess, Barb, I would ask you, we're about 10 past 5.
We're okay.
We're okay? All right, good.
Yeah.
As long as we're okay.
Okay, Chris, we can just go right to the next slide. I'm going to jump to that. So we do want to share sort of what's happening now. We did have legislation in 2022 that had us to update the state Alzheimer plan, but it also codified the Dementia Action Collaborative, meaning we are now in law. And, it also served to refresh our membership a bit with a group of governor appointees for our membership. And we were required to address certain elements in the plan and an annual report to the legislature, which we were doing before voluntarily. But it does sort of elevate the issue of dementia and makes it a little more visible, I think, in state government. So in the process of updating our state plan, we reached out, as we did with the first plan, to consumers across the state. We did surveys, we did listening sessions, and tried to really say what is the state of dementia right now. We had more than 2,000 people answer an online survey. We had more other people come to listening sessions, and we were hearing themes that individuals and families were really struggling with the cost. I'm sure you guys hear that, of residential care or in-home care, that family members are needing a lot of support with providing care, struggling while they're trying to work and trying to provide care. We were hearing that healthcare, long-term care, and first responder systems all needed more education around dementia. We were learning that, families and people out there really need help, but they often just don't know where to go and where to turn for help. Despite all our efforts trying to get information out there, people still are struggling with where do you go for help. It really became clear that our communities just need to become more age and more dementia friendly. We need more help in the communities to help people understand what services are available and what people can do to make their lives a little bit easier when they're faced with dementia, either themselves or within their families. So on the next slide, I also wanted to share that not only we were looking at the needs, but we were looking at what were the opportunities going forward in our updated plan. So, one of the things that happened is that since we published the first Washington State plan, a lot more good evidence and research had come out about the issues of maintaining brain health and potentially modifiable risk factors for dementia. So potentially modifiable risk factors aren't saying that you can necessarily prevent dementia, but that you can impact some of those lifestyle and behavior changes that can reduce a person's chances of developing a disease. So information that was published in the International Lancet Journal shows that you can look at strategies through the life course. And if you look at what you could do in early life or midlife to help reduce the risk for dementia, that they have identified that with these factors, nearly 45% of all dementias might be presented or delayed. So if you're looking at the screen, I know it's really tiny and you might want to go to the article, but many of the modifiable risk factors for dementia are related to cardiovascular disease or other chronic conditions. So they include hypertension, lack of physical activity, obesity, diabetes, smoking. These are all things we know in terms of healthy aging in general, right? So there's other factors across the lifespan, such as depression, excessive alcohol consumption, or other harmful substances, hearing loss, poor sleep. So it's really becoming clear that maintaining a healthy lifestyle in general, including engaging in lifelong learning and socialization, along with managing chronic conditions through the life course, is good for your overall health and improves brain health and may help to decrease the risk of dementia or slow its progression. So if you go to the next slide, we took this information and tried to really think about what we needed to do in those areas to improve our plan at this update. So we have very similar goals as we had the first time. And what you need to know is that under these 7 goals, each goal has several strategies. And in all, we have about 144 individual recommendations to work on some of these complex issues. So if you go to the next slide, I just do want to share some of the things that have worked for us in terms of guiding principles for the way we do implement our work. And one of the things we've tried to do, because this is so big and complex, is we're trying to really stay person and family centered. What's going to make a difference? We're really focusing on health equity. We're focusing on using that life course perspective to sort of look at the short and the long term. We're building upon other work whenever we can. As Chris mentioned, we borrowed from Minnesota, the Act on Alzheimer's. We borrow from the CDC Healthy Brain Initiative, the National Alzheimer Plan. Wherever we can build on something that is working, we will try to do that instead of recreating the wheel. And then one of our real big tenets is to stick with that whole public-private sort of framework that we started out with, because we think that that has been working really well and is probably one of the only ways to really make an impact. So what can you look forward to? We just want to leave you with some ideas about what what are some of the big things that we're working on in this update. So this isn't everything, but a few things. I know the new and ongoing efforts that Chris was talking about related to primary care practitioners. We just need to keep at that with Project ECHO, the cognition with primary care. We're actually holding a new a summit called the Dementia Innovation Summit on March 7th, which is targeted towards primary care. And we'll put a little bit of a link in there. I don't know, Chris, if you have it, or I'll get to it later, but that's going to be a very exciting summit for primary care. We're also working sort of at the state level to create an age and dementia friendly state, and then working with communities to create more age and dementia friendly communities. So this is a new initiative. This was signed by Governor Inslee last April, and we are working. You'll be hearing more about that over the course of the next year or so as we do a statewide survey and look at ways to sort of create more age and dementia friendliness in all of our communities. A third thing that is big on our agenda is increasing awareness. We're going to continue around brain health and dementia and the signs and symptoms. We're doing this in several different sectors. We're working on it in healthcare. We're working on it in public health through a Department of Health learning community with local health jurisdictions, and through some funded projects, as I mentioned earlier, with community-based organizations and faith-based organizations. And as Chris mentioned, through the Dementia Friends program. And another area of our real focus is making sure we're creating new opportunities for family caregivers to get education, training, and support. So in this updated version of the plan, we wanted to be really clear how people like you can help. So people that aren't necessarily fully engaged with the Dementia Action Collaborative, but that there are things that people can do to align with the plan. So we were going to have Chris give you a couple examples here.
Happy to do that. So there's a couple of different pieces here that are back here. There we go. So there's some links and resources around ways that you can encourage folks to promote healthy brain habits across the lifespan. Certainly being involved in Project Echo if that is something that is interesting to you and fits with your kind of needs. There's some great resources around ways to make sure that family caregivers are identified and clearly documented in the medical record, sharing the dementia roadmap, the toolkit, all the things that we've talked about. There's also a palliative care roadmap that was based on the dementia roadmap. That's a wonderful resource. So lots of things that you could implement into your practice. And I look at these things and I think about providers that say, why would I diagnose dementia? There's nothing I can do. There's nothing I can offer anybody. And these are all things that absolutely people find so meaningful and not disease modifying, but course altering, I think. So,
Chris, were you wanting to show some slides? Because there's no slides showing at the moment.
Really?
It was there. I could see it. Interesting.
Huh.
Well,
It's up here.
it says I'm still sharing, but I'm just going to trust that it's happening.
Okay, well, maybe everybody else is seeing them and I'm not. Sorry.
That's okay. That's all right. All right. And I guess we've got a couple of minutes to chat about kind of lessons learned and some takeaways. Lynn, what would you add?
Yeah, I know we're running really short on time, but I do just want to add, as I think about this, I remember, us talking about we didn't really want it to sit on the shelf. But one of the things we were really aware of is that in order to make this happen, you really have to put the effort in, right? And you have to be working across these sectors. So I would say that the two sort of really key approaches is working across sectors and working sort of in this multi-sector environment. Because when you look at this, from the state perspective, this increased number of people with dementia is just daunting. And we have workforce issues, we have financial impacts for individuals and for the state. We really need to leverage the opportunities that all these different sectors bring to us. So looking at both that life course approach, what could we do to delay the onset, to reduce the risks, the number of people who will have them, have dementia. And, the reason, when I'm looking at this pie, I think about healthcare, and you think a primary need is healthcare for people with dementia. But we knew, for example, in our state plan that our primary care providers did not feel confident in making diagnoses. At the same time, as Chris mentioned, consumers weren't talking about it. They weren't asking their physicians about it. So you can't just, try to educate the health providers without educating the consumers. And you have to work on the stigma, because the stigma is part of the reason that people aren't wanting to talk about it. So it's all sort of connected. And you think of these multifaceted problems like dementia, they need multifaceted solutions. Right? So they're all connected, and we need to continuously be working across these sectors, looking at the short-term and the long-term sort of life course perspective in order to really address the problem in a real way. So we are, when you look at this sort of pie, we have all these different programs we have shared with you today, and all these different things are working with a piece of the problem, but they're all sort of connected. And I think that's the value of the collaborative work we've been doing, is that we're sort of staying aligned in our messaging. We're sharing resources, so we're not having to recreate. We're not having to duplicate work. We're sharing resources across sectors and taking advantage of the knowledge that we have within the collaborative. So that is something sort of key if you're trying to create some real change, is working together like that. And then just leaving you with a few of the key lessons learned. One of the things we found in our first plan is that there's so much in dementia we can't change right now. We have to focus on the things we can. And the hope and empowerment factor has been a big thing, is not only for the people in our membership, but for consumers out there to really focus on what are the things you can do to stay healthy? What are the things you can do to plan ahead, to bring your family in? So focusing on hope, looking at lived experience has been really valuable for us. I can't imagine doing this kind of work without the people that we had in our collaborative who were sharing their life experience with dementia. And then, I just do want to reiterate, if you're ever working on this kind of collaborative setting, you need staff to support the work, because we have a lot of people, communication, relationship building. You really need to have people who are going to stick with it. And ideally, people who are both passionate and committed, because it takes a long time. So you have to have a lot of patience and tenacity to keep going and support each other in this kind of hard work. So I think, Chris, is there anything else you want to add to that before we jump to questions about some of our takeaways?
Yeah, I would only add that, we also benefited from a really fantastic facilitator for the meetings, just to help kind of keep things on track, and get that many personalities in the mix, and it's hard to maintain momentum. So she has been just another active ingredient, I think, in getting that done. Yeah, so no, otherwise I think we've got time for questions, and I don't know, Lynn, I want to be respectful of your time. I'm happy to hang out. I don't have anything else.
Yeah,
that
I'm good.
So, okay.
If they're still here, I'm still here.
All right, here we go.
So I do have a couple of questions saved up, and then maybe some others will come across in the chat. Diane is asking if you know about Montana's plans and resources, or where people can look for that kind of information for their state.
You mean if they have a state Alzheimer plan?
Yes.
We looked at that recently. I think that they do have a plan. Yeah, I just found it. I'll put a link in here.
Oh, great.
Yeah.
And
you never know. Every state is different. I don't know what they have in their plan, but they do have one.
And then Richard was asking, I think in reference to some of the legal planning and that sort of thing, there are some families that are kind of dysfunctional, fighting over money, and things kind of fall apart. Do you have conflict resolution information or mechanisms to recommend to help people work through that?
Like Chris can answer that, but what I'll say is, from our state level, we have what is called a family caregiver support program across the state. We have people in every county that are family caregiver support specialists, and they often work with people. They are not mediators themselves, but they can help people understand some of the issues at play, help them sort of pick apart what are some things we could help you with. So I would say, if you are, trying to figure out who in your area might be able to help a family who is struggling, the first place to go would be with the Family Caregiver Support Program. We have a very robust program in our state, and I would encourage anybody to find that. They're housed in their area agency on aging. And so if somebody has a question and wants to get to that in their local area, just please put it in there and I'll link them up with their local people.
Yeah, I was going to ask, because it seemed like that might be a AAA or an area agency on aging might be a place to contact to find out about some of that.
Yeah, and I'll put the phone number in here. If we can get a question for Chris, I'll go find the phone number for the family caregivers.
The only thing I would add to that is that that's a attorney specific kind of a thing often. So that I hear from both the attorneys and then families that some attorneys feel like they have the skills to kind of help with that, and then others have mediators or other resources they like to use. We as a clinic don't have conflict resolution kind of machinery that we can implement, but what we do advocate is ensuring that when it's like estate planning time or other advanced care planning time, that the person's wishes are documented as clearly and consistently as possible, as early as possible, and then kind of revisited just to lock in, like, these are the person's wishes. And it doesn't matter what the family wants necessarily, although it still devolves into chaos at times. So that's the only thing I would add to that.
Yeah, I could mention, I used to serve on the state's professional guardianship board, and it's a huge issue for guardians as well to navigate some of those questions and concerns.
Yeah, the only other thing I will add, and kind of relatedly, is I do capacity evaluations as part of my neuropsychological work, and will occasionally do retrospective evaluations. And oh my gosh, it's messy, in terms of the issues when there are changes and things haven't been documented clearly, and when there hasn't been a good documentation of cognitive function by a provider that it's contemporaneous with decisions that are made. So I would encourage you all to think about that too.
So Richard is saying that they just redid their plan, and the AAA in Missoula, Montana, has a plan that's much like the one in Washington that he's a part of. People who access it are helped, but unfortunately, too many do not reach out, and that's kind of the challenge, is to have them be aware that it's there.
Absolutely.
Yeah.
And then Cindy mentioned, as a long-term care ombudsman, many of the memory care residents are left alone and deteriorate rapidly. What ideas could she bring to infuse some energy into a facility given short staffing and high turnover? Thoughts on that? Great question.
That is a great question, and it's an ongoing struggle. And I'm assuming that you're meaning, I don't know what kind of, you're talking about maybe a assisted living memory care setting that you're talking about. I think there are resources. If you were to call the Alzheimer's Association, for example, they may have some ideas and resources. There are whole associations around activities. I don't know if you're talking more about activities or more about healthcare. I think, there is a state law, the state office of the long-term care ombuds might have some resources for you. If you continue to struggle, feel free to reach out to me. My email is on here, and I can find somebody in our agency who could potentially get you to somebody who could provide a little more meaty information for you, because it really depends on the situation and what you're seeing. Thank you for the question, though. I think it's an ongoing struggle.
We had a question earlier. Someone raised their hand, but it's sort of hard to open things up. I don't know if Ayala can pose the question in the chat. Other questions while we explore that from folks? She said it was just an error. I'm wondering if you have done work or connected with other states, Lynne or Chris, as they've worked on some of their plans, and what's that experience been like in terms of sharing lessons learned and that sort of thing?
Yeah, Chris, I don't know. I mean, from my point of view, yeah, we talked to other states a lot. When I first did the plan, I talked to like 5 or 6 states that had done it within the last year or two. So I picked their brains quite heavily. And people are constantly calling us for, ideas and resources. And one of the struggles I would say in a lot of states is that people get stuck within one silo. Like, we get calls from people who are potentially working in the Department of Health, and they can't make any headway with their aging division, or they're in the aging division and they can't make headway with the Department of Health or links with healthcare. So I would say one of the struggles that I hear the most is around that connectivity. And I think that's where when I at the beginning said we're really fortunate, is because we have been able to do that through the structure we have of having different staff people and the chairpersons that we have. I think we've been able to share information pretty readily. And I would say states are wonderful. Anytime you call us, we're very willing to help people, and they're very willing to help us. I mean, everybody is struggling with very similar challenges. None of us have the answers. We're all learning together. I think that's the thing to keep in mind, is that this is a long-term issue, and it's complex, and there's no simple way to do it. It's really trying a lot of things. Chris, you probably talked to other states as well around ECHO.
Oh, definitely. And, not just ECHO, but also some of the, the health and medical priorities. So, I got a chance to visit with a couple of the main architects of the state plan for Minnesota out there, and everyone, I would echo that. Everyone's been so helpful and gracious and giving of, tools and resources and learnings, and it'd be great to be able to pay that back.
So Diana is asking a sort of difficult question, because I think people are still figuring things out, but she asks if some of this grant funding is at risk given the current political climate or changes in funding.
I think all of us are nervous with the state budget the way it is. You know, we don't know anything and we don't know what's going to happen. So right now we're all just hanging in there and hoping for the best. And you know, we've just been very fortunate. We've had such a supportive legislature with the things that we have asked for. I think they understand the issues, you know, but these are tough times. So yeah.
All right,
Stay
I do want to
tuned.
remind everyone that we will be having Mary Grace Becker from the Memory and Brain Wellness Center, and who has been instrumental with the Dementia movement in Washington State. She's going to be talking next week on supporting dementia-friendly communities. So some more boots on the ground kinds of experiences, and I invite you back. And Chris and Lynn, thank you. This was magnificent and so informative. Really appreciate it.
Great to be here. Thank you.
Yeah,
Have a nice
absolute
evening,
pleasure.
everyone.
Excellent.